Bismillahirrahmanirrahim. Quote of the day. Feed your iman with the knowledge of Quran. It will help you on the day of judgment. Assalamu alaikum everyone. I am Dr. Hussain Mahmood. Today I am presenting on randomized control trial under current supervision of my professor Dr. Sarah Afzal. Learning outline. Today we learn about introduction of randomized trial, history of randomized trial, classification, advantages and disadvantages, procedure of trial, ways of expressing and analyzing data, peer review, and ethical consideration at the end. Learning outcome. At the end of this presentation, participant will be able to describe about the introduction of randomized trial, classification, ways of analyzing data, recruitment process along the ethical consideration and recent updates. Introduction. A randomized control trial is a form of scientific experiment used to control factors not under direct experimental control. Examples of randomized control trials are clinical trials that compares the effect of drug, surgical techniques, medical devices, diagnostic procedures, and other medical treatments. Participants who enroll in RCTs differ from one another is unknown and unknown way that can influence study outcomes and yet cannot be directly controlled. Study population randomly assigned new treatment, current treatment. New treatment is divided into improvement and don't improve, and current treatment is into improve and don't improve. History. The first published randomized control trial in medicine appeared in 1948 paper entitled Streptomycin Treatment of Pulmonary Tuberculosis, which described a medical research council investigation. By the late 20th century, RCT was recognized as the standard method for rational therapeutics in medicine. As of 2004, more than 150,000 RCTs were in the Cochrane Library. The first reported trial was conducted by James Line in 1747 to identify treatment for scurvy. The first blind experiment was conducted by the French Royal Commission on the animal magnetism in 1784 to investigate the claims of mesmerism. An early essay advocating the blinding of researchers came from the Claude Bernard in the latter half of the 19th century. Bernard recommended that the observer of an experiment should not have knowledge of the hypothesis being tested. RCT in clinical research. An RCT in clinical research typically compares a proposed new treatment against an existing standard of care. These are then termed the experimental and controlled treatment respectively. When no such generally accepted treatment is available, a placebo may be used in the control group so that participants are blinded to their treatment allocations. This blending principle is ideally also expanded as much as possible to other parties, including researchers, technicians, data analysis, lists, and evaluators. Effective blending experimentally isolate the physiological effect of treatment from various psychological sources of bias. By the late 20th century, RCT was recognized as the standard method for rational therapeutics in medicine. As of 2004, more than 150,000 RCT were in the Cochrane Library. A well-blended RCT is considered the gold standard for clinical trial. Blended RCT are commonly used to test the efficacy of medical intervention and may additionally provide information about adverse effects such as drug reactions. A randomized control trial can provide compelling evidence that the studied treatment cause an effect on human health. Classification. By the study design from most of the least common in the healthcare literature, the major category of RCT study design are parallel group. Each participant is randomly assigned to a group and all the participants in the group receive or don't receive an intervention. In crossover study design, over time, each participant receive or don't receive an intervention in a random sequence. In cluster study design, pre-existing group of participant village schools are randomly selected to receive or not receive an intervention. In factorial study design, each participant is randomly assigned to a group that receive a particular combination of intervention or not non-interventions by outcome of interest, efficacy with effectiveness. RCT can be classified as explanatory and pragmatic. Explanatory RCT tests efficacy in such setting which highly selected participant and under highly controlled condition. In contrast, pragmatic RCTs test effectiveness is in everyday practice which relatively unselected participant and under flexible condition. In this way, pragmatic RCTs can inform decisions about practice by hypothesis superiority with non-inferiority with equivalence. Another classification of RCT categorizes them as superiority trials, non-inferiority trials, and equivalence trials, which differ in methodology and reporting. Most RCTs are superiority trials in which one intervention is hypothesized to be superior to another in a statistically significant way. Some RCTs are non-inferiority trials to determine whether a new treatment is no worse than a reference treatment. Other RCT are equivalence trial to in which the hypothesis is the most interventions are indistinguished form of each other. Advantages of RCT. The advantages of proper randomized in RCT includes it eliminates bias in treatment of assignment, specifically selection bias and confounding bias. It facilitates blinding, masking of the identify of treatment from investigators, participants, and assessors. It permits the use of probability theory to express the likelihood that a difference in outcome between treatment group merely indicate chances. RCT are considered to be most reliable form of scientific evidence in the hierarchy of evidence that influence healthcare policy and practice because RCTs reduce spurious causality and bias. Result of RCT may be combined in systematic review, which are increasingly being used in the conduct of evidence-based practice. Another benefit of randomization is that to whatever extent it contributes to comparably, that contribution applies both to variable we can measure and to variable that we cannot measure and may not even be aware even though they may important in interpreting the finding of trial. Procedure of RCT, the treatment allocation is the desired proportion of the patient in which treatment arm. An ideal randomization procedure would achieve the following goal: maximize statistical power, especially in subgroup analysis. Generally, equal group sizes maximize statistical power. However, unequal group sizes may be more powerful for some analysis. Multiple comparison of placebo versus several dose using donuts procedure and the sometimes desire from non-analytic reason. Patient may be more motivated to enroll if there is a higher chance of getting the test treatment. The regulatory agency may require a minimum number of patients exposed or treatment. Minimize selection bias. A good randomization procedure will be unpredictable, so the investigator cannot guess the next subject group assigned based on the prior treatment assignment. The risk of selection bias is the highest when the previous treatment assignment are known or can be guessed. Minimize allocation bias or confounding bias. This may occur when the covariates that affect the outcome are not equally distributed between treatment group and the treatment effect is confounding with the effect of covariates. Recruitment and retention of study participants. A major change in the conduct of randomized trial is to recruit a sufficient number of eligible and willing volunteers. Failure to recruit a sufficient number of volunteers can leave a well-designed trial without a sufficient number of participants to yield statistically valid result. Potential participants must be willing to randomize for the trial. Sample size determination. The number of treatment units assigned to control and treatment group effect of RCT reliability. If the effect of treatment is small, the number of treatment units in either group may be insufficient for rejecting the null hypothesis in the respective statistical test. The failure to reject the null hypothesis would imply the treatment should not statistically significant effect on the treatment of given test. But as the sample size increases, the same RCT may be able to demonstrate a significant effect of treatment even if this effect is small. Blending. An RCT may be blended, masked by procedure that prevents study participant caregiver or outcome assessor from knowing the intervention was received. Online allocation concealment blending is sometimes inappropriate or impossible to perform an RCT. For example, if an RCT involves a treatment in which the chief participants of the patient is necessary, physical therapy participant cannot be blinded to the intervention. Unblended. RCT without blending are referred to as unblended open or open label. In 2008, a study concluded that the result of unblended RCT tended to the bias toward beneficiary effect only if the RCT outcome were subjective as opposed to objective. For example, in RCT of treatment of multiple sclerosis, unblinded neurologist, but the blinded neurologist felt that the treatment were beneficial. Analysis of data. The types of statistical method used in RCT depends on the characteristics of the data includes for dichotomous binary outcome data, logistic regression predicts sustained virological response after respiration of PEG interferon alpha 2 for the hepatitis C, and other method can be used. For continuous outcome data analysis of covariance for the change in the blood lipid level after respite of atorvastatin after acute coronary syndrome. Test the effect of predictor variables. For time to event outcome data, they may be censored, survival analysis, Kaplan-Meier estimators, and Koch's proportional hazard model for time to coronary heart disease after respite of hormone replacement therapy in menopause is appropriate. Regardless of the statistical method used, important consideration in the analysis of RCT data includes whether an RCT should be stopped early due to interim result. For example, RCT may be stopped early if an intervention produces larger than expected benefits or harms. If investigators find evidence of no important difference between experiment and controlled intervention. The extent to which the group can be analyzed exactly as they existed upon randomization. A pure intention to treat analysis is possible only when complete outcome data are available. For all randomized subjects, when some outcome data are missing, options include analyzing only case with outcomes and causing input data. Nevertheless, the more the data can include all participants in this group to which they were randomized, the less biased data at RCT will be subjected to. Whether subgroup analysis should be performed These are often discouraged because multiple comparison may produce false positive findings that cannot be confirmed by other studies. Interpretation of statistical result. Like all statistical methods, RCT are subject to both type 1 and type 2 statistical error. Regarding type 1 error, typical RCT will use 0.05 as the probability test, and RCT will falsely find two equally effective treatments significantly different. Regarding type 2 error, despite the publication of 1978 paper, nothing that the sample size of many negative RCT were too small to make definite conclusion about the negative result. Here, the possible outcome of randomized trial type 1 and type 2 error. In possible conclusion, we conclude treatment are not different from each other, and we conclude treatment are different from each other. In reality, treatment are not different, and treatment are different. In cell A, correct decision. In cell 2, cell B, type 2 error. In cell C, types 1 error, and in cell D, type correct decision. This is the figure possible outcome of randomized trial alpha and beta error. In possible conclusion, we conclude treatment are not different from each other, and we conclude treatment are different from each other. But in reality, treatment are not different, and treatment are different. In cell A, correct decision. In cell B, probability type 2 beta error, and in cell C, type 1 alpha error, and in cell D, correct decision. This is the summary of terms. Alpha is probability of making a type 1 error, probability of concluding the treatment differ when in reality they don't differ. Beta is probability of making type 2 error, probability of confirming that the treatment don't differ when the reality they do differ. Power 1 manfi beta type 2 error, probability of correctly concluding that the treatment differ, probability of detecting difference between the treatment if the treatment do in fact differ. What must be specified to estimate the sample size needed in randomized trial? The difference in response rate to be detected and estimated to be response rate in one of the group, the level of statistical significance alpha. Fourth is the level of power desired 1 manfi beta, whether the test should be one-sided or two-sided. Ways of expressing the result of randomized trial. The result of randomized trial can be expressed in a number of ways. The risk of death of developing a disease or complication in each group can be calculated, and the reduction of the risk can then be calculated. Efficacy of agent being tested, such as vaccine, can be expressed in the term of rates of developing disease in the vaccine and placebo group. Efficacy is equal to rate in those who receive the placebo, negative rate in those who receive the vaccine over rate in those who receive the placebo. This formula tells us the extent of reduction of disease by the use of vaccine. Risks are often calculated per person year of observation. Efficacy or how well a treatment works under ideal condition may be differentiated from effectiveness or how well a treatment works in real life situation. Although randomized trial most often evaluate efficacy of a treatment, the two terms efficacious and effective are often used interchangeably. Interpreting the result of randomized trial, generalizability of result beyond the study population. Whenever we carry out a trial, the ultimate objective is to generalize the result beyond the study population itself. Let us consider an example. Suppose we want to evaluate a new drug for lupus erythematosus, a connective tissue disease, using a randomized trial. For example, the total population might be all participants with lupus erythematosus. The Defined population might be all participants with lupus erythematosus in our community. And the study population could be participants with the disease who receive their medical care from one or several clinics in our community. This shows the external validity and internal validity in part A. External validity total includes external validity includes total population, defined population, and study population. In group B, show internal validity. Internal validity includes study population, randomized, new treatment, current treatment, and comparative effectiveness research. Some randomized trials are designed to compare a new therapy to a placebo. Other randomized trials focus on comparing a new treatment with an older accepted treatment in order to determine whether a new treatment is superior to the established treatment. In this type of approach, results from other type of study design, which are discussed in the coming chapter, may be used together with the finding of randomized trial to try to answer this question. Peer review in RCT. Peer review or result in is an important part of the scientific method. Reviewer examine the study result from potential problems with design that could lead to unreliable results. Evaluate the study in the context of related study and other evidence. Evaluate whether the study can be reasonably considered to have proven its conclusion. To underscore the need for peer review and the danger of overgeneralizing a conclusion, two Boston area are medical research perform a randomized control in trial with the randomly assigned either a parachute or empty basket to 23 volunteers who jumped from the either a biplane or a helicopter. The study was able to accurately report the parachute failed to reduce injury compared to the empty baskets. Advantage: RCT can be expensive. A disadvantage: RCT can be expensive. The conduct of RCT takes several years until being published. Thus, data is restricted from the medical community to longer years and may be loss of relevance at the time of publication. It is costly to maintain RCT for the years to decades and would be ideal evaluating some interventions are prevent. So to prevent events that occur only frequently, an uncommon adverse effect would require RCT and extremely large sample size and may therefore be best to assess by the observational studies. Ethics: if a disruptive innovation in medical technology is developed, it may be difficult to test the ethically in an RCT if it becomes obvious that control subjects have poorer outcome, either due to other forgotten testing within the initial phase of RCT itself. In social sciences, due to the recent emergence of RCT in social sciences, the use of RCT in social sciences is contested issue. Now, recent updates. A randomized trial compared the scientific carbohydrate diet to a Mediterranean diet in adults with Cochrane disease, Crohn disease. The study compared the effectiveness of the specific carbohydrate diet with the Mediterranean diet as treatment for Crohn disease with mild to moderate symptoms. Method: adult patient with CD and with Crohn disease and with mild moderate symptoms were randomly assigned ratio 1 to consume the MD and STD for the STD for 12 weeks. For the first 6 weeks, participants received prepared meal and snacks according to their assigned diet. After 6 weeks, participants were instructed to follow the diet independently. The primary outcome was symptomatic remission of at 6 weeks. The key secondary outcome week 6 included the fecal calprotectin response and the reduction by 50% among those the baseline FC and the C-reactive protein response result. The study randomized 194 participants and 191 included in the efficacy analysis. The percentage of participants who achieved symptomatic remission at week of 6 were not superior, with the STD FC response was achieved in 8 and 23 participants. Conclusion: the STD were not superior to the MD to achieve symptomatic remission. This is another randomized trial of orlistat or silodrestat for the treatment of Cushing's disease. Abstract: Cushing disease, a chronic hypercholesterol disorder is associated with considerable morbidity and mortality. Normalizing the control of product of the primary treatment goal. We aim to evaluate the safety and efficacy of only oscillodrestat, a potent orally available 11 beta hydroxylase inhibitor compared with the placebo in patients with Cushing disease. In result, 73 patients, median, received randomized treatment with the oscillodrestat at 12 weeks, significantly more oscillodrestat than placebo, 8%. Patient achieved MUFC more than ULN. Response was maintained at week 36 when 81% of all participants achieved MUF. Conclusion: oscillodrestat rapidly normalized MUFC accretion in most patients with the Cushing disease and maintained their effect throughout the study. Now it's time for MCQ. A researcher conducted an RCT to test the efficacy of new antihypertensive drugs. Participants are randomly assigned to receive either the new drugs or the drug or a placebo. What is the main purpose of randomization in this trial? A, to ensure all participants receive the treatment at same point. The minimize bias and balance both known and unknown confounding errors. To increase the sample size for more statistical power. To ensure participants are blinded. Treatment they receive to guide the study result will be statistically significant.
B.
It's B, yes. In RCT, evaluating a new treatment for diabetes, participants in the treatment group show significant improvement compared to the placebo group. The researcher claimed that the treatment is effective with treatment would most strengthen this claim. The study was conducted in only one center. The participants were not blinded to their treatment. The study had a high dropout rate. The allocation concealment with the adequately maintained. The control group receive active treatment rather than placebo.
Delta. D.
Yes, it's D. In a multi-center RCT assessing new cancer treatment, the results show varying level of effectiveness across different centers. What is the possible reason for this variation? Differences in outcome measurement and used in each center. The sample size was too large. The randomization method was not appropriate. The center implemented the same protocol with no adjustment. The patient in each center had different baseline characteristics. It's E. Yes, it's E. During a RCT, participants are followed up for 6 months to measure the primary outcome. Which of the following best describe the intention to treat ITT analysis? Only including participants who adhered strictly to the treatment protocol, analyzing the data based on the treatment participants received regardless of group they were assigned to. Include all participants in the analysis as per the group they were initially assigned, regardless of whether they were completed the study. Excluded participants who did not complete the study or with treatment. Analyzing the most favorable outcome to support the primary hypothesis. It's C, including all participants. A double-blinded RCT is conducted to evaluate a new vaccine. Midway through the trial, a third-party data monitoring committee recommends stopping the trial early due to clear benefits. What is the most ethical reason for stopping the trial at this point? To save resources and reduce costs, to publish positive result earlier, to provide a new vaccine to all of participants as soon as possible, to avoid any potential negative effect on the participants, to prevent participant attrition.
A.
Let's see, to provide new vaccine. A double-blind randomized control trial is conducted to compare the effectiveness of drug A versus drug B in reducing cholesterol level. What does double-blind mean in context of this trial? Only the participant know what treatment they are receiving. Only the researcher know which treatment the participant are receiving. Both the participant and the researcher don't know which treatment of participant are receiving. The trial has no control group. The trial used two different types of blending techniques.
C.
Yes, it's C. In RCT assessing a new antibiotic effectiveness of treatment for pneumonia, the adult show the intervention group has a statistically significant reduction in recovery time compared to the placebo group. Which of the following can be concluded from this study? The new antibiotics cause pneumonia. The new antibiotics has no effect on pneumonia. The new antibiotic may be effective in reducing recovery time for pneumonia. The placebo was better than antibiotics. There was no randomization in the trial.
Charlie. C.
Yes, it's C. A researcher wants to test the efficacy of new drug for treating hypertension. He recruits 200 participants and randomly assigned them into two groups, one receiving the new drug and the other receiving the placebo. Both drugs are following for 6 months and their blood pressure is measured at the end of study. What type of trial in this cohort study? Case control study, cross-sectional study, randomized control trial, and observational study. It's D, randomized control trial.
D.
A randomized control trial is a form of scientific experiment used to control factor not under direct experimental control. What if the following potential limitation of randomized control trial? They have a high risk of selection bias. They cannot establish causality. They are generally expensive and time consuming to conduct. They don't provide reliable results. They are ineffective for comparing new drugs.
C. Charlie.
Yes, it's C. In an RCT studying an experimental treatment for chronic pain, researchers find a statistically significant reduction in pain scores in the treatment group compared to the control group. What does statistical significance imply? The treatment is granted to be effectiveness for all participants. The result is unlikely to be due to chance. The treatment group had better baseline health compared to the control group. The trial was biased in favor of treatment group. The trial is effective only for the duration.
A. Alpha.
It's B. The result is unlikely to due to. This is key for our MCQs. This is our YouTube channel. Kindly like and subscribe. Thank you.